Hi, my name is Andrew Kornstein. I'm a cosmetic plastic surgeon. I do non-invasive, minimally invasive, and conventional rejuvenative cosmetic surgeries. Today I'm going to talk to you about how the face ages. We'll go over the anatomy, and we'll talk about non-invasive modalities that are able to reverse most of the signs of aging. Everything I'm going to talk about today are areas that I innovated myself, including profound and the use of your body's fat cells, which are the most potent stem cells in the body and can rejuvenate the volume and the circulation to your facial skeleton, slowing or even reversing aging. I hope you enjoy the presentation, and I look forward to answering your questions at the end of the presentation. I'd like to start tonight's presentation with a brief discussion of anatomy. Anatomy is important because it helps the patient understand how aging occurs and also why certain procedures make more sense than others. In a phrase, aging is more than skin deep. In a simplified fashion, the face is divided into 5 basic layers: the skin, the subcutaneous fat, the superficial facial muscles, the facelift layer, and the facial skeleton or bone. These layers all undergo and participate in the aging process. From the front view, the same 5 basic layers are visible. However, from this view, one can see that there is a continuity between the forehead muscle or frontalis muscle, the facelift layer in front of the ear or SMAS, and the platysma muscle in the neck. This is important because traction or tightening in one aspect of this continuous layer can help remedy aging in an adjacent area. Let's look at the procedure. Profound was developed through rigorous scientific testing, the kind of testing that rarely exists today. My colleague and friend spent roughly 8 years working on perfecting a target temperature to rejuvenate the skin of the face. When this target temperature is achieved, the genes within the skin are turned on, restoring hydration, collagen content, and elasticity. There is also a coincident skin tightening of about 30%. The Profound machine checks this temperature roughly 10 times per second. By doing this, the patient and practitioner are assured that this target temperature is being delivered to the skin, optimizing the outcome. In about 2019, I published a paper that discussed rejuvenation under the skin. In this paper, I used the profound technology to go beyond the skin into the superficial facial muscles. Those muscles are the muscles typically treated with toxin, or most commonly referred to as Botox. And these muscles include the forehead muscles, the muscles around the eyes, the muscles around the mouth, and the chin. So when we go deep to the skin, we can create rejuvenation in a second layer, the skin plus the superficial facial muscles. Again, the forehead muscle, which is responsible for transverse forehead wrinkles and eyebrow position, the muscles between the eyebrows, which is responsible for inner eyebrow shape and wrinkles between the eyebrows, the muscles around the eyes, which are responsible for wrinkles in the lower lid and crow's feet region, the muscles around the mouth, which are responsible for smoker's lines, upper lip length, lip volume, and also the chin muscle, responsible for lower lip position. So onto the aging process. The triangle of youth essentially shows that there is more volume in the mid-face than in the lower part of the face. In addition, there is a high arched brow, a separation between the upper eyelid skin and eyelashes, no wrinkles between the eyebrows or in the crow's feet region. There's also a smooth, continuous contour between the lower lid, the cheek, and the nasolabial folds. There is an oval lower face and a tight neck contour. These are all reversed over time through a loss of underlying bone and fat support. In other words, the deeper layers, the facial fat and the facial bone layer, undergo atrophy, leading to a loss of youthful contours and a loss of anti-gravity support and subsequent descent of the soft tissues. In a nice summary, one can see on the left side of the slide youthful skin and aged skin with loss of hydration, collagen content, and elasticity, leading to wrinkles and sagging. One can also see a loss of facial fat, resulting in loss of mid-facial volume and anti-gravity support. On the right side of the slide, one can see changes in the facial muscles, including redundancy, which can be tightened with profound, and also, and finally, a loss of skeletal volume, most readily seen in the size of the eye socket, the bones around the nose and upper lip, and the jawline and chin. A close-up of the eye socket shows that in youth it's more round. As it gets older, it becomes more ovoid. Loss of bone in the area of the inner eyebrow leads to loss of eyebrow support and descent of the inner eyebrow, and a contraction of the muscles between the eyebrows, leading to wrinkling in that region. Loss of bone in the lower lid, outer lower lid region exposes fat from the eye socket as well as a loss of support for mid-facial fat, leading to a descent of this fat to positions lower in the face, such as the nasolabial fold and the jowl. On the left, one can see the change in position of the nose. It is frequently mentioned that the nose does drop with age, and that is because of a loss of underlying support of mid-facial bone. As the bone is lost, the support for the nasal tip is lost and the tip drops. This same area of bone loss is responsible for a sagging or elongation of the upper lip, as well as loss of upper lip volume. On the right, one can see the significant amount of mandibular bone loss that occurs with aging, leading to a loss of jawline contour and support, resulting in descent of the jowl forward toward the chin, as well as descent of neck soft tissues under the chin, leading to an accumulation of those tissues where they're commonly seen as the first signs of neck aging. So, as a summary, all of these stigmata of aging, the very things that you come to your surgeon to address, all have an underlying reason or foundation that is, in short, a loss of volume and anti-gravity support through loss of bone and fat. This typically occurs in the late 40s and early 50s. I've never seen this published, but I've known for many years, and my patients have knowingly nodded, that somewhere in the 46 to 48-year-old age range, there seems to be an acceleration of the aging process. I believe this is due to a loss of circulation to the bone, and with the loss of circulation comes an acceleration of bone loss, facial volume, and anti-gravity support. In women, there's also hormonal issues, most commonly loss of estrogen with menopause. And estrogen is extremely important for collagen strength. And with this loss of collagen strength leads to additional loss of anti-gravity support and soft tissue descent. So we cannot replace the missing bone, but we can replace the missing fat and use the fat, when properly grafted, to replace the missing bone volume, as well as to restore the loss of circulation. Fat grafting has gotten more popular over the years. However, it is not done the same way in every office. Many offices use it as a filler, doing it under local in the office, injecting fat in multiple sessions, where the fat acts more like a natural filler than a living, viable stem cell. When grafted from one area of the body to another, this requires a trip to the operating room and meticulous technique whereby the transplanted cells can gain blood supply and survive. When they survive, they replace the missing fat volume, bone volume, and can act as the body's most potent stem cells, restoring circulation to the facial skeleton. So we have seen that there's aging at the skin level, the superficial facial muscle level, down to and including the facial skeleton. So what can we do non-invasively that can help rejuvenate the face in light of these changes? These procedures are powerful, but they are not as powerful as a surgical technique when done in the right hands. However, for many patients, an office-based procedure leading to significant improvement is a viable alternative to a surgical procedure. In the lower right-hand corner of this slide, one can see that the profound probe is now under the skin, and it is in the interval between the facelift layer and the skin. One can also see that there's a connection between the deep layer of the face and the skin. These fibrous septi or ligaments are collagen connections, not unlike the strings on a parachute between the skin and the deep facelift layer. Tightening in this region leads to remodeling of the collagen within the facelift layer, as well as the collagen overlying the neck muscle. It also leads to remodeling and tightening of the fibrous septi, drawing the skin tighter and closer to the facelift layer. Shown on the table during the procedure, one can see this patient with half the face treated and half not, that on her right side the cheek has been elevated. It is in continuity with the lower lid, and the lateral aspect of the cheek has been restored. There is also a submalar or sub-cheek hollowing, and the jowl has been elevated from under the jawline. The opposite is true on her left side, where there's a hollowing in the lateral aspect of the lower lid. The cheek has descended, and there is a loss of lateral cheek volume. The jowl has descended below the jawline. Again, using the triangle of youth, one can see on the patient's left side how soft tissues have descended away from the mid face toward the jawline, and on the table the correction that could be achieved, re-elevating these tissues into their more youthful and anatomic position. Looking at this patient from above, one can see on the right side the submalar hollowing, which is an aesthetic feature of a youthful face, the harmonious integration between the cheek and the lower lid with filling of the lateral cheek. On the patient's left side, the stars represent the loss of submalar hollowing, loss of fill in the lateral lower lid due to cheek descent, as well as loss of lateral cheek volume, again due to soft tissue descent from underlying bone and fat atrophy. And again, a comparison with the triangle of youth, where there is descent on the patient's left side and restoration of volume distribution on the patient's right side. Again, this occurs on the table during the procedure due to contraction and will be followed by collagen remodeling. Similarly, the neck muscle or platysma can be rejuvenated with this technology. On the patient's right side, the jowl has been elevated above the jawline, whereas on the left side, the jowl still remains below the mandible. This is due to elevation of the, or I should say, this is due to a tightening of the facelift layer above, drawing the jowl back into its normal anatomic position. We also can tighten the platysma in a posterior vector, leading to significant tightening and contour of the neck. The diagram on the right shows that tightening of the tissues in the midface draw the redundant neck muscle from under the jawline in a superior direction, and tightening in the posterior direction eliminates the remainder of the neck redundancy. Some patient examples. I want to point out that these are not facelift procedures, again, but they do follow the anatomy and theory of a facelift procedure. This patient had conventional profound on the left. On the right, she is roughly 3 months after the deep profound. And again, I would say there's a significant improvement in facial contour as well as soft tissue youthfulness. With the chin tilted up, we could better see the restoration of the mid-facial volume and the shortening of the upper lip, as well as revolumization of the upper lip and the elevation of the corners of the mouth. With the chin tilted down, you could see that the gravitational descent of the soft tissues around the jowl have been reduced. There's significant improvement in the mid-facial volume and a significant reduction in neck soft tissue accumulation. Once again, another view showing improved soft tissue health and viability, a reduction in crow's feet, a higher cheek, and a loss of redundant jowl tissue. This patient, like many patients, has an asymmetry with more tissue on her right side than her left, and that has led to refinements in this procedure. Like all innovations, things are not born into their perfect form, but are refined as time and experience progresses. I now have found a way to adjust for patients with additional redundancy, ameliorating this minor asymmetry. Close-up views show an improvement in brow contour as well as loss of crow's feet wrinkling. Again, improved harmonization of the cheek and lower lid with reduction in crow's feet and reduced forehead wrinkling, reduced crow's feet, and improved harmonization from the cheek to the lower lid. Even as someone approaches 80 years old, there is redundancy in the skin, there is redundancy in the superficial muscle layer, and redundancy in the facial soft tissue or facelift layer. In order for there to be a significant improvement non-surgically, the redundancy in these three layers must be ameliorated as best as possible. The redundancy of the eyelid muscles are significant before profound and much improved after profound in the deep layer, treating the superficial facial muscles in someone nearing 80 years old. In patients with thin skin, lip wrinkling is very common and fillers look obvious. The more philosophically correct and anatomically correct modality would be tightening the redundancy of the muscles around the mouth. By doing so, there's significantly less wrinkling, no obvious filler, and the upper lip can be shortened and the upper lip volume can be augmented naturally by creating more volume where it belongs, behind the red lip, reducing or eliminating the requirement for fillers. Elevating and tightening the tissues of the midface pulls redundant neck tissues back where they belong, eliminating significant redundancy in the jawline and neck. Again, not a facelift, but with significant improvement. Some patients achieving much better results than others, depending on soft tissue quality. This patient, approaching 70 years old, never had any prior treatments, and therefore her tissues required rehabilitation from a qualitative point of view as well as a quantitative point of view. There is significant qualitative improvement as well as contour improvement for a one-time non-surgical alternative in someone who otherwise would not be a good non-surgical candidate. However, by treating more than the skin layer and treating the underlying supporting layers, these patients can achieve significant improvement as well. Thank you very much for listening, and I look forward to addressing your questions.